Good afternoon, everyone, and thank you so much for taking the time to join us this afternoon. My name is Dr. Eduardo J. Gomez. I'm Associate Professor in the College of Health and the Director of the Institute of Health Policy and Politics. You're joining our colloquium series here at the College of Health at Lehigh University. And the colloquium series started about two years ago when the college started, that invites experts from around the world to talk about several population health issues. And each semester we have a different focus. Our focus this semester is on women in health. And today we are honored to have with us Dr. Werner Obermeyer, who is the director of the World Health Organization at the Office of UN Headquarters in New York City. Dr. Obermeyer, his portfolio includes the promotion of health in the General Assembly and other intergovernmental bodies and processes, the WHO's relations with the UN system entities based in New York, as well as non-governmental organizations that focus on public health. He was responsible for the negotiations which culminated in adoption of the 2011, 2014, and 2018 political declarations on the prevention and control of non-communicable diseases, the 2016 political declaration of antimicrobial resistance, and the 2018 political declaration of tuberculosis, the 2019 political declaration of universal health coverage, and the 2022 political declaration on road safety. Following the title of Dr. Obermeyer's presentation today is the World Health Organization at 75, Fit for Purpose. And after Dr. Obermeyer gives his presentation, we'll be joined by two student panelists from the College of Health, Emma Klossner and Jessica Berman, who will provide some questions to Dr. Obermeyer. And then following those questions and discussions, we'll be opening up to the rest of you for any questions that you may have. So without further ado, we'll go ahead and switch over the presentation and have Dr. Obermeyer give his presentation. Thank you.
Thank you very much, Ed. And a special word also of appreciation from my side for inviting the World Health Organization to participate in the colloquium today. It is an honor to be speaking to you. And what I'm going to do is to give you a little overview of the work of the World Health Organization, or WHO as we call it, where we stand today in terms of global challenges, health challenges, the impact of the pandemic, and then we focus more on gender equity and the role of women in health. So the title of the presentation is very appropriate. The World Health Organization will be 75 years old next year, so I thought to call us Fit for Purpose is a good example of healthy aging in practice. So if we look at the first slide, the next one, which would give you a little overview of where the World Health Organization is active. We have the most country offices of any of the UN system entities in 150 locations. And we actually made a little bit of history earlier this year at our executive board meeting and subsequent health assembly, where our budget was increased by 11%. It's the first time in about 2 decades that there has been a budget increase for any UN specialized agency. So we have a budget now of around $6 billion for a 2-year budget cycle, which is not a lot of money if you compare it to most medium-sized cities here in the USA have a larger budget, annual budget, than ours for every 2 years. So the objectives which we have redefined in the next slide to be working on as corporate priorities are what we call the triple billion, and that is to make change in the lives of 3 billion people, for 1 billion to ensure that they have access to universal health coverage, for another billion to enjoy better health and well-being, and a third billion to be better protected against any kind of health emergencies or health threats. So where are we in terms of these objectives? In terms of the first one, achieving 1 billion more people having access to universal health coverage, we will not meet the target which we had set for this year, and we have rolled it back now to 2025. The reason is quite simple. We are about 730 million short of a billion, reaching a billion, largely due to a decrease in funding for health, but specifically also due to the impact of the pandemic. The pandemic has interrupted essential services for health in about 94% of countries to a varying degree. So the shortfall is likely to be more than around 730 million people. And we are in severe danger, actually, of achieving the targets and sustainable development goals of universal health coverage for all people by 2030. In the past 2 decades, there have been successes. We have seen some improvements, particularly in the length of life, the daily, as we call it, adjusted disability life years, people's improvement in life in Africa and in Southeast Asia. But this progress has been very slow. It has actually been turned around by the pandemic. The next slide gives a slightly better picture. The question around health emergencies. In the last 5 years or so, the World Health Organization has dealt with around 50 health emergencies. These are, of course, not all very well known to the public. COVID-19 is most probably the one dominating the news. We have seen countries actually be better prepared for health emergencies. Since 2018, we have tracked this and seen a lot of systemic improvements, but the pandemic obviously has rolled back a lot of the progress, particularly in terms of equitable access, prevention strategies, catch-up vaccination efforts. These are all things that would need to be scaled up and recovered post-COVID. In terms of healthier lives and well-being, the picture is a little mixed. We have made a lot of good progress, actually. We are around the 900 million mark out of 1 billion. And that is largely due to improvements we have seen in access to clean household fuels, to safe water and sanitation, and tobacco control. But in other areas like maternal health, malnutrition, and overnutrition or obesity, there have been marked decreases. So to achieve the global target that we have set, we would need to focus not only on funding, but also on improving access to policy solutions in the recovery period post-COVID. The next slide will give you a very good overview of the disease burden we are dealing with. This has not changed too much from 2019, but it shows you a good overarching picture of how the burden varies not only among regions, but more drastically actually in the income categories among countries, from low income up to high income. The 10 top causes of death, as you will see in the next slide, are those deaths or those disease burdens that cause around 55% of deaths. That's 55 million annual deaths, more or less, every year. The vast majority of these are due to non-communicable diseases. And the evidence there is quite striking. Non-communicable diseases cause about 70% of deaths. And this will increase towards 2030 if we don't address it. The graph will indicate clearly there to you that heart disease carries the highest risk of premature death, particularly for women, in more than 1/2 of all countries. And we are also seeing a troubling trend in the spread of pathogens through poor sanitation and contaminated water. Environmental risks actually contribute to 80% of diseases in most developing countries. And particularly this year, the evidence is striking. There are 29 countries that have reported cholera outbreaks, which is much larger than the global average every year. And the first point of contact, of course, with unsafe water and sanitation often are women and children, which makes this problem even more dire. The service coverage index on the next slide is an indication of where we are in terms of providing universal health coverage across the world. There has been improvement in many of the regions. The service coverage, as I said earlier, will be interrupted, and we have, through our Global Pulse survey, which we have ramped up during the pandemic to track which service deliveries have been interrupted, seen that there will be a slowdown in the progress that we have made because of the pandemic. The next slide gives a good overview of where most of the health gains have been made. Interestingly, between 2000 and 2020, the African region had the largest growth in terms of 22 index points in service coverage index, and also in life expectancy, a gain of about 12 years of life expectancy over those 2 decades. We also track in the next slide the pursuit of universal health coverage through a financial protection indicator. And this is very important because you will see a substantial number of people in the world, around 1 billion people, still spend more than 10% of household budget on health, which is what we call out of pocket. And about almost 300 million spend a quarter of their household budget out of pocket. So this leads to a great deal of people, more than 120 million every year, becoming impoverished because they have to sell assets or borrow money for healthcare. The barriers in the next slide to protection, financial protection, is shown, and you will see there that the number of people spending more than 10% of their household budget actually increased from 2015 to 2017 because of disposable income. And when people have more disposable income, they actually look for better health care. And in many countries like India, for example, the private sector is now providing the vast majority of health services. So the more money people have as disposable income, the more they look for better health care, and obviously the more they spend. And then that is economically not a feasible model if there is no financial risk protection. In 2 years, we have seen in the next slide the interruption of services I mentioned a little earlier. This has been dire across the world, 92% of interruptions. And this would not be so serious if it were in secondary and tertiary care. But in the slide following, you will see that the service delivery interruptions are actually in areas where we can least afford it. Half of the countries have reported interruption in routine immunization, 40% in terms of essential health services, which is your cancer care and other non-communicable disease prevention and rehab. And 1/3 of all countries had interruptions to sexual, reproductive, maternal, newborn, child, and adolescent health. So you'll see in terms of primary health care is where you deliver around about 90% of all health interventions. The interruption has been more than 50%. So the unseen effects is something that we will grapple with for some time to come. In the next slide, I want to move now more to the gender perspectives. Gender obviously has implications for health across the course of every person's life. It influences how you are exposed to emergency situations, to diseases, access to healthcare, water, sanitation, and such. And gender inequity disproportionately affects women and girls, obviously. In most societies, they have a lower status and less control over decision-making about their own bodies, intimate relationships, families, and communities. They are exposed to violence, coercion, and harmful practices, still in many countries. And women and girls, obviously, as a result of that, face very high risks of unintended pregnancies, sexually transmitted infections, cervical cancer, violence, and other challenges. Gender inequality also poses a barrier to women and girls to access health information. And we see that particularly here in the UN, when there is a discussion about sexuality education, there are at least 2 or 3 dozen countries that don't even want to talk about it and leave the room immediately. So women's access to information, restrictions on mobility, decision-making, access to financing, lower literacy rates, these are all things that are still at play and which we are battling hard to overcome. It's been an uneven road, to be frank, because progress in terms of women's health, which is a key cornerstone of WHO's work, have been a fight against discrimination, ethnic discrimination, but also class and disability discrimination. In a survey we did among 64 countries, we found that at childbirth, professional help was only available for about 55% of women in poorest households. And if you compare this to rich countries, professional help is available in more than 90% of households. So to improve access to healthcare and invest in primary health, but in particular, we need to focus on women, investing in women, but particularly also, I would say, focusing on investing in health workforce that is predominantly catering for women, but also services delivered by women. The next slide is what I was referring to about women in the health workforce. 70% of people that work in the health workforce are women, but only 25% of leadership roles are filled by them. So they work predominantly in unpaid informal roles, they lack social protection, and they also experience violence and harassment. So what we have done with a number of key countries in WHO is to invest in best practices that foster equal pay. And to address this, we have a program which is called Gender Equity, Health and Care Workforce Initiative, which we are implementing across the world with the participation of women in the health sector. And this is aimed at improving the role of women and the number of women in leadership and decision-making roles, and also by focusing specific measures on women to protect them so that they have equal access, for example, to personal protective equipment, to COVID-19 vaccines, and protection against sexual and other forms of harassment and violence at work. The number of women in the next slide desiring to use family planning has increased a lot, quite remarkably over the last 2 decades or so. From 900 million, it has gone up to almost 1.1 billion. And the number of women using modern contraceptive methods have also increased from around 660 million to 850 million. So that means that the proportion of women of reproductive age that require family planning and which need to be addressed have increased quite slowly, despite the number that have required access to the services. We see the slow increase about from 73% to 77% over the last 2 decades as a result of some bottlenecks which are limited access to services, particularly among young and poorer and unmarried people, cultural or religious opposition, which is still a very big barrier in Africa and in Latin America, and poor quality of available services. So that is one of the cornerstones of universal health coverage, to have quality and effective services, because to have a service point that are 400 or 500 miles from rural communities satisfy the statisticians, but it doesn't satisfy the people or their needs. So there are a lot of gender-based barriers still in place. In fact, during the initial stages of COVID, when we were tracking discriminatory practices, we found that in 70% of countries, there were disruptions to vital services, which women access as a matter of routine in terms of sexually transmitted diseases and unwanted pregnancies. So women could not access those as a direct consequence of the pandemic. Financing reproductive health services under universal health coverage, as I alluded to, is one of the key package of essential services that WHO promotes as part of any country's rollout of universal health coverage. In fact, this is one of those investments that, with a little bit of money upfront, can have major returns. So in order to meet women's needs in most middle and lower income countries, you would need to invest around $9 per person annually. And this would result in the underfunding, which currently affects 4 billion people across the world, markedly improving access to services that they require. Unfortunately, a lot of the money that is spent on sexual reproductive health and services come from external donors. It's not domestic financing. So around 10% of all external donors supporting programs related to health channel their money to sexual reproductive health services. But this is a problem because as the donor attention to health becomes strained as a result of the pandemic, budgets are shrinking all over, larger domestic investments are required, and we have not seen that needle move. Maternal mortality have been one of the things that we made a lot of progress in up to the pandemic. 35% fewer women die from causes related to pregnancy now than 2 decades ago. So this is a major improvement. But once again, the Sustainable Development Goal, the health goal, has a target that aims to reduce maternal mortality, the ratio, to fewer than 70 per 100,000 live births. We are not there yet. We are only there in some of the regions, but we are a little bit further behind in others. In Africa, we're only 40% on track to meet that target, and in Southeast Asia, 55% on track. I want to spend a little time on something which is very relevant and important, which is how to prevent and respond to violence against women, which I mentioned earlier on has become specifically pronounced during the pandemic because of people being in lockdown for many reasons, also an increase in substance abuse. But this is something which is an underlying societal problem and needs to be addressed in all sectors, not only in the health sector. It took many decades, really, I think, for this topic to become one that the public is interested in and to talk about it openly. It used to be dealt with in many societies as a private thing behind closed doors that you don't speak to in front of children and families. So it's something that we have made a big breakthrough in internally in the UN system, in WHO, but also in the work we do, where we advocate for the end of any kind of forms of violence or harassment against women and girls. We actually launched a study last year, the biggest global study ever, to track the prevalence of violence against women and girls. And we found that 25% of adolescent girls that had an intimate relationship were subjected to physical or sexual violence by their partner by the time they reach their early 20s. So this is an endemic problem. We have launched with a UN organization called UN Women, a gender-based violence prevention initiative. It's called Action Coalitions, where we partner with several community organizations to focus attention on and prevent and implement measures to prevent sexual violence. And of course, if you look at how this has become an instrument of war in some countries and how this has become a widespread problem we deal with in refugee settings or in settings where migrants are housed. It is something we need to focus on through the media much more. We have, for example, we work in many of these areas where WHO is tasked by the UN system, by the Secretary General, to lead what is called the Standing Committee to deal with all health issues in humanitarian and the emergency settings. So we have deployed teams on prevention and response to violence against women in Syria, in Ukraine, in Poland, and in areas where this is something that wouldn't normally be reported because of the conflict. So it's necessary to go look at the root cause in such settings. In terms of the prevalence of such violence or intimidation, as I mentioned a little earlier, you see there that the numbers vary quite starkly, and it is much, much higher in low-income countries. It's high, unacceptably high all over. But if you see on the slide there where the differential lies, it is clear to us that a lot of work needs to be done on the education side. I want to start wrapping up now, but speaking a little bit more about non-communicable diseases and women and the gender disparity. You remember I said earlier that the non-communicable diseases are the cause for about 70% of all deaths every year. Cancers in particularly, cervical cancer is the fourth most common cancer among women, an estimated 600,000 cases every year and about 340,000 deaths. But of course, very well known, 2020, for example, there were almost 2.5 million cases of breast cancer, 700,000 deaths globally. There were 7.8, almost 8 million women in 2020 diagnosed with breast cancer. So we are actually reaching more people with the diagnosis. It is the world's most prevalent cancer in men and women. And it is also true that men can develop breast cancer. So the aim that WHO has to deal with this very large threat of breast cancer is to reduce mortality every year by 2.5% until 2040. We are moving ahead and it looks to be on track if we can keep up the diagnostics. I would just want to emphasize, for example, despite the focus on cancers, it's very necessary to also have a particular emphasis on the prevention of NCDs, which you can also tailor policies to be more gender responsive. So there are certain things, that you undertake to prevent non-communicable diseases, such as a healthy diet, physical exercise, moderate use of alcohol, tobacco cessation. These are things which are easily implementable in terms of an aggregated response. So there are specific policies that we have developed targeted at women and girls. It is true that most non-communicable disease deaths are men, but it for women can be prevented much more effectively by tailoring policies, specifically gender-based. I want to next move on to mental health. Mental health is a very important topic. We estimate that the long-term effects of the COVID-19 pandemic in terms of the mental health burden will dwarf what we have seen in terms of the number of deaths so far, which are already extremely high, 6 million. Women's health obviously cannot be adequately addressed without focusing on mental health. So you have three categories of people that normally are those that are more prevalent to mental health conditions: the elderly, adolescent women, and then women of childbearing age. So there is a lot of data that shows the effects of pregnancy and birth, early parenthood on women's mental health conditions. And of course, there is a lot of data that also shows how social determinants affect mental health conditions, particularly for women, because of economic dependence on men, for example, violence, intimate partner violence. I've spoken to this already, and we can maybe in the Q&A talk a little bit more about the mental health burden. Something that's often not really seen or spoken about is how the environmental risks and climate change affect women, which is a very interesting new growing area of focus for our work also. Climate change, obviously, as we all know, has long-lasting impacts on health, well-being, and the environment. It affects those things that we need most for human health: land, water, and other natural resources. Women, obviously, because they constitute the majority of the world's poor and are more dependent on natural resources, are under threat by climate change. And environmental degradation obviously affects the livelihoods, especially in rural areas where subsistence agriculture is often the responsibility of women. So the nutrition aspects related to that are becoming more and more pronounced. The women and children are also most at risk in the increasing number of countries where natural disasters occur, floods and storms and droughts, as I mentioned. So the adaptive capacities that we develop as a society need to be also gender-based, and we need to look specifically at how we deal with women and how they can be the first line of defense, really, in terms of dealing with environmental degradation and adaptation to climate change. Coming to the end, I would just want to wrap up with something which is really important for us in WHO. We actually 5 years ago established a position in the organization called the Chief Scientist. It was filled by an excellent scientist from India, Dr. Sumya Swaminathan, who has now retired. But it showed us that there is really a very, very large gap in women in science leadership positions across the world. And because of that, there is also a very large discrepancy in cohorts or studies that we do in terms of the efficacy of new drugs and new medicines, where the reporting is not inclusive of gender balance. So it is something that we probably have highlighted not only in science and research, but can use as a driver when we look at the COVID-19 response and recovery. And if we look at how we build back in the final slide, it's important that we focus on highlighting the role of women in particular as we prepare for the next pandemic, and there will be another one sooner than we anticipate. Let me close by showing you a picture of one of our colleagues and visiting our website if you need any more information. We're also very happy to share the slides with you if you found it interesting or useful for your further work at Lehigh. I'm now in your hands for all the most difficult questions you can imagine.
Wonderful. Thank you so much, Dr. Obermeyer. That was a fantastic presentation. So much information for us, and very much enjoyed that. We're going to now turn to our panel of undergraduate students. And today we're joined by Emma Kloster and Jessica Berman, who are in our College of Health and have been taking classes and working on global health issues, are also involved in our university partnerships with the United Nations. And I'd like to turn first to Jessica Berman for any questions and thoughts she may have about your presentation.
Thank you for the presentation. It was very informative. My first question for you is, what have been the long-term implications of the Gender Equity Healthcare Force Initiative? And is this program implemented in all countries, or just the countries you believe, or the World Health Organization believe, are in most need?
Well, we implement those initiatives in the countries which actually request it from WHO. That's one of the limitations, I would think, in our work, that it is not easy for us to implement initiatives, particularly around women, in all countries that we may think require them. We have to do this with the cooperation of the country in question and the government. And then the policies that we promote are not always to the liking of the governments concerned. So it's a little bit of a tight balancing act we walk. We are also a little constrained in terms of funding, because to roll this out costs money. It's an investment. So there are donors like Canada and Spain that have stepped up quite markedly, and then there are best practice examples. For example, countries like Costa Rica have really very good models that we are using now to implement across Latin America. And it's always better to have an example that you take to a health ministry that's based on something that they are familiar with. So from one of their neighboring countries, and they are willing to cooperate much easier if that is the case.
Thank you so much. And I was also going to ask you, which you sort of touched on, was that if funding trends are different when developing policy targeted towards women and girls. And I was wondering what those trends are and if you're surprised by these trends.
No, not at all. If you look at how money is spent on health, you'll be surprised at how underserved areas like mental health, which everyone acknowledges is a major problem, only receives about 4% of national health budgets. And the money spent on mental health interventions are poorly spent. They are spent on looking for institutional drivers that can affect change, rather than treatment programs that can be rolled out at community level at very low cost, and training people in order to undertake those interventions without having to be medical professionals. So you find exactly the same thing in investing in gender equity, that a lot of the investments are financed by countries of the North to be implemented in countries of the South. But the models that are implemented are not tailored for domestic needs. So by simply looking at the socioeconomic aspects related to improving gender relations and gender parity in many of the developing countries, you can actually achieve much better results with the same kind of money. So it's a continuous conversation we are having with donors to spend their money better and spend it more effectively, by not necessarily doing what they think is best, but to listen to where they are spending the money, what can make a better difference. And this, after all, benefits them politically too, because they have to justify to their own taxpayers how many people they reach efficiently and effectively with the costs that they lay out.
Thank you so much. Another question I have is, you said that sexual and reproductive health services are disrupted when health systems are under pressure. When does the WHO know when to step in before it is too late? And how do you know when the health system is under too much pressure to work effectively on their own?
Well, you know, I would say that if there is a global outbreak like we face now, there is not a single country. As I said, more than 90% had service delivery interruptions in one or two areas. And it is like having a fire, but you only have a small number of fire engines in the brigade that you can send out there. And while you're fighting a fire, there is another one. So where do you deploy your assets to deal with a crisis? So obviously the hard decisions made by ministers are to take funding away from areas which are more routine and to divert it to those that are in dire need of alleviating a crisis. So the first area where they look for savings are prevention, screening. And this is where the largest dangers actually are evident, because if you don't screen people for hypertension, if you don't screen people for mental health conditions, if you don't invest in women's and children's health, the spin-offs beyond the health sector are severe. So by making decisions in the health sector to deal with a crisis, you're actually causing multiple crises down the line. So these are things that for us in WHO, we have a lot of experience in terms of seeing it happen. But there is a very fine diplomatic line you need to walk by explaining to politicians in countries, this is what you need to do. And this is how you need to function according to what we have learned. Because you must always keep these people in a kind of a relationship that they want your advice, and you are not overburdening them with their advice. So this decision-making authority should not be WHO's, it should be that of the national government with our advice. It's a tricky thing to do. I was talking to some students at the Columbia University not long ago, and they asked me, what do you think is the most effective way of changing people's minds? And the most effective way really is when you can speak to people in a way that they listen what you're saying, but they also hear what you're saying. You can influence them in such a way that they will take a decision in exactly the way that you intend them to take the decision. But it is their way of making and arriving at a decision, which is actually the success. That's the objective you need to have. So it goes to education, but it also goes to soft diplomacy in a way, particularly if you deal with governments that are under pressure to deliver, because they are the ones responsible for the health of their population. And it's very difficult to tell them how to do it because they are the ones that are elected by the population. I just want to say, you know, before we go to the next question, I spent a lot of time talking about investing. It's not only investing on the financing side. A couple of years ago, I was in a workshop with some people that were leading different health programs. I was there for World Health Organization. There were people from other organizations, and a good old friend of mine, actually, Michael Myers, who was the executive director of the Rockefeller Foundation at the time. We each received a question from whoever was facilitating the session, and said, if you have a blank check, not necessarily a financial check, but if you could move something, what would be where you make the investment? What shows the best results? And Michael said, there is no better investment than investing in girls' education. And that is really the key thing, because you educate not a person, you educate a generation. And you educate men. So this is a kind of investment that I see is the ideal for improving women's health. Investing in education, literacy, health literacy. You may, of course, disagree.
Thank you. And a follow-up question I had from before is, do you think more efforts, like efforts towards health and financially, are made towards prevention rather than solving current issues, or are efforts relatively equal?
No. It's quite the opposite. It's simply human nature not to focus on prevention. And that's why every time there is a pandemic, we sit in a similar situation because of the panic and neglect cycle. So hopefully the lesson we will learn out of COVID is, if you invest in a resilient, strong, functioning health system, based universal health coverage, based on an effective structure that delivers primary health care, you are eminently equipped to deal with any kind of shock, natural disaster or otherwise, because your health sector is prepared and does not function independently. So a lot more needs to be done in terms of prevention, not only in the health sector. I mean, if you look at how the market reacted to this, and how the financial institutions reacted to it, very slow, as if no lessons had been learned to prevent it.
So I have a question. You mentioned the words due to the pandemic multiple times throughout this, and like how important it is to take proactive steps. And so my question is, what proactive steps are the WHO taking to like kind of minimize impacts in the future? And also, I could be making a leap here, but to go back to kind of how there has been a budget increase that you mentioned at the very beginning of your presentation, does that indicate that there's more investing in public health? And if not, what do you think that indicates?
Well, the investment in public health have been shrinking actually for quite some time. If you look at investments in prevention of non-communicable diseases, it has been stagnant for the last 25 years. So it's definitely not been increasing. The increase in the budget for WHO is something that we are really very excited about. And I'll tell you why. Not because we are the first organization that received a modest increase of 11% or so, but there was an agreement for a multi-year increase to lift what is called the unearmarked part of our budget to 50% of our total budget. Now, our budget is a complicated thing to explain, but I'll try and break it down and simplify it for you. Out of the 6 or so billion, at least 75% of that money is earmarked. So the money that we are given by Gates Foundation, by the member states, the governments, the countries that are members of WHO, have to be spent in areas where they designate the money to be spent. So that's earmarked. So if you deal with the pandemic like COVID-19, and we have to establish the ACT accelerators to ramp up first the diagnostics around analyzing the virus, then producing countermeasures, then developing a vaccine, then rolling out treatment, and rolling out also things that you need to protect your health workers to deal with the pandemic, you need a lot of money up front. And if you have no flexibility in the money that's sitting in your budget, then you have a problem. So once you have that kind of flexibility in moving money quickly to deal with a shock or a crisis, you can show to the world how effective you are at dealing with it. But if you're hamstrung by the fact that you can only spend 2 out of every $10 in your pocket to deal with something that is becoming a major crisis, then obviously, you're not going to get anywhere fast. So that's why, in terms of the budget increase, it's something that we are very excited about. But of course, when people promise you money, it doesn't mean they're going to deliver it. So let's hope for the best. I hope all of you will advocate after this call that we have had, that people should actually make good on their promises in terms of delivery. You had another part to your question aside from the WHO's budget. Just remind me of that, please. I don't want to miss it.
I was curious on how you think, like, kind of getting at the root of like why that budget increase happened, and like where, like, since you're saying that it won't necessarily go towards public health, and in reality the public health budget has been shrinking, like, where is this increase coming from and why is the WHO getting that? Because we obviously understand that, but in the minds of policymakers, it might be a little bit different.
Well, the money we get from governments come from their finance ministries, which is a bit of a convoluted argument, because it's the same finance minister that needs to give the health ministry an increase in their budget domestically. So the hope is that if there is a realization that you need to invest more in global public health, you will also realize that you have to invest more in domestic health resources. So that is where we will spend a lot of our energy to make sure that it happens also at the national level. Because for us to have a modest increase in capacity, what we are doing doesn't translate into action at the country level. I mean, it should be equally equipped for us to make a real difference. I just like, in terms of looking at how we can deal with the whole question of health financing and health governance better. This pandemic, there are about 300 recommendations that have been made over the last 10 years because of pandemic outbreaks. The first respiratory outbreak, SARS-1, then MERS in the Middle East, then Zika, the Ebola outbreaks, Marburg, the latest Ebola one in Uganda, and of course, COVID-19, SARS-2. It has all shown us that there are 3 elements missing. One is flexible financing, nimble way of dealing with the crisis. Second, there is a difficulty, there's a problem with trained people. You need to have a core group of people you can deploy, not WHO staff, experts across the world that you can ask to go to an area where there is a crisis and intervene before it becomes a global one. That does not exist despite us calling for this for the last 15 years. So there are legal ways to get around this problem, and we hope we will get to it soon. But then there is also the governance issue. WHO is recognized as the global public lead on health, but we operate in a landscape where there are multiple foundations that have more money and do the same work as we do, and do it with the same governments in the same countries. The experience of those governments in those countries are not always so pleasant, when it comes to civil society bulldozing into their backyard and telling them what to do and spending money in rural communities where the government doesn't have any reach. So it's a bit of a political minefield sometimes. So that is why the investment in what is now a negotiating process in Geneva to result into in a new treaty, which will regulate how WHO can function more effectively in the health crisis situation, is one area where a lot of investment and time is now being made, because it will hopefully increase our mandate so that if there is an outbreak in country A, and we read about it on social media, we don't have to wait 4 weeks for the government to give us permission to go and look and see what's happening there. While they clamp down in their own country, but allow their people to fly all over the world and spread the virus. You see what I mean? I'm not attributing this to any country, a hypothetical country. But this is the reality of the world we live in. If you don't have the authority to say, you must report such an outbreak to us within 24 hours. And, countries can just wipe their nose and look the other way and there are no consequences. Then you will have this issue. And you will have it forever. So that is one improvement we hope we can make on a legally binding way, for example, in the next 2 years, if the lawyers agree to it. And so let's live in hope for that too.
So I kind of have a separate question away from like the political intersection. I'm curious about the rising topic of environment and climate change and women's health. And could you go more into how you see women's health being impacted? And given that not that climate change is a new issue, but that it's been more part of the conversation recently and we're seeing the effects of it, what are some ways that the WHO is planning on addressing this and trying to get ahead of these issues that we're intending to see?
Well, I have some colleagues which are actually women, because the brain trust in our office are all women. They are online and they know more about this than I do. But if I call them to say something, they will forever hold it against me. So I'm going to try and give you my take on it. I'm from South Africa, so you see the wonderful Table Mountain in the background of my picture. We are familiar with a drought-stricken country, so I can give you some examples from my own personal perspective. Women are the ones that are tasked with agricultural sustenance in most rural and semi-rural areas. They're the ones responsible for feeding the family. They're the ones responsible for bringing water from wherever there is a point of delivery to the household to make sure the water is clean. That is, that conforms to the proper standards for drinking, which is obviously not always the case. So when you have nature intervening and those life-giving forms that you rely on, which is water and land, do not provide for you anymore, then women suffer first, because the meager amounts of nutrition go to the men. This is what happens in society. And then to the children, and lastly to the women. So they are affected in practical terms the worst. It's not only in many African societies, this happens all over the world. The elderly also are at the back of the line. So this is simply something that is a terrible blight on society, but it is the truth. The second example I have seen many times in North Africa, where I spent many years. Whenever there is such an outbreak of a natural occurrence like a drought, or there is an insurrection or some violence, women and children are the ones that bear the brunt, because they have to pack up their belongings and flee. And they are the ones ending up in refugee settings, and they are the ones left destitute, living under shreds of canvas for years on end. With no way to make ends meet, and deserted by the men. So essentially, you have refugee camps with tens of thousands of people in Sudan, in northern Kenya, in Somalia, which are consisting only of women. And they are environmental refugees. They are not there because of conflict. They are the ones that bear the brunt of it. So it is something that is overlooked, it's not reported, but it's something that if you see it firsthand, you will you will never forget it. You remember it for the rest of your life, and needs to be talked about more. I hope that's, I mean, it's a good practical way of explaining it to you. But we can send you more information if you need from us, the data that we have collected on it.
Yeah, no, I've never thought of it in that kind of perspective. And like that was I am understanding what you're saying. I guess I'm curious the ways that the WHO intends to kind of get involved in those areas and kind of what you can do to the best of your ability.
Yeah, so what we do when something like that, in terms of the refugee camps, we are responsible for providing the healthcare with our partners, such as MSF, the Doctors Without Borders, and all the civil society groups that operate in those areas. WHO's country offices are responsible for providing, for example, insulin for diabetics, emergency care, whatever mental health services we can deliver in such areas, which obviously is way too little. And then there are other organizations like the World Food Program. They're tasked with providing nutrition and food, and then you rely on donations. We work a lot with Rotary, for example, in such settings to vaccinate people. Because they are a strong partner of ours, not only in polio eradication, but in many other neglected tropical diseases as well. So you see it firsthand. You talk, and you talk to your members, the members of WHO, the countries, when they attend the World Health Assembly, and that is how you make it more, let's say, more of a household problem. Because that's usually where you have the issue that something like that, you see a report in the New York Times once every blue moon, and then it's the end of it. No difficult questions. You've only been asking easy ones.
Thank you so much, Emma. Is that, do you have any other questions?
I have a few, but feel free to ask the ones in like the Q&A. I see there's a few in there.
Thank you so much, Emma. We do have some questions from the audience, and I'd like to go ahead with the first question from Lori Hertz, who's joining us. Is it difficult to receive funding for safe abortion care, especially since many in the US opposing funding for abortions?
Well, we receive our funding not from specific sectors of society. So the work we do in terms of family planning do include access to safe abortion, and that is a stated policy of WHO. And a lot of the work that we roll out at country level in this area is funded by European countries. And is actually also funded by the US administration. So there are many programs through which we work with the administration in Washington, irrespective of who is in power. PEPFAR, for example, has existed for many, many years. It's a strong partner with us on HIV, TB, and malaria prevention. And irrespective of who is walking the hallowed halls there, they provide funding for us. So it's in terms of the more politically, how shall I say, difficult topics like this one, you don't rely only on one donor, you rely on everyone providing you with the funding, and because one or two may not like what you're doing, you don't stop doing it. If there is a need, then we need to fulfill it. That's our constitution. In one of the early slides, you may remember there was a reference to our constitution, which is to ensure the highest attainable standard of health for everyone, everywhere, irrespective of where they're from, what their race, religion, or distinction they may have.
Great. Thank you, sir. Thank you very much. Our next question is from Dr. Bill Hunter here at Lehigh. The US has announced a moonshot funding stream to try and reduce or cure cancer. Is this the most effective approach to disease eradication, or should it become more of a global effort to do so?
You know, I have a personal antipathy when it comes to moonshot technology. Usually this is funded by some venture capitalist that has a good idea and a lot of extra money to spend. And it's invested in ways that are supposed to come up with what is called a silver bullet. And more often than not, it results in some experimental drug that never makes it through the regulatory process. But it gathers a lot of media attention and is reported on all over. And even if the early clinical trials may show some success, it's only those that are at the very top ends of society that benefit from it. So in terms of rolling out health to those people that are most vulnerable and most in need, they've never heard of any moonshot, and for them it makes no difference what you call it. I mean, there are ways to invest in prevention of cancer and cancer treatment that are much easier than looking for a one-stop solution.
Great, thank you so much, sir. Our next question is from Professor Erica Holscher, who is here at Lehigh University. Dr. Obermeyer, thank you for the presentation. The women's health concerns that you outlined are matters of concern for people across boundaries of geography, financial and social status, age, etc. How aware are women of these healthcare deficiencies, and what is the main factor that helps them to advocate for themselves?
Yeah, I think, you know, I don't want to talk specifically about access to healthcare here in the USA, but I think it has been documented publicly how certain sectors of society, particularly those that are less educated or more impoverished, have lower health outcomes and access to lower quality services. And so this is a barrier I think you don't only find here, you find it everywhere. So a lot of the work that probably needs to be done more effectively is on health literacy, but health literacy that starts at school, to educate children first and foremost, because this is one area where we saw COVID-19 had a dramatic impact in terms of not only the science, math subjects that children fell behind in countries where there were lockdowns, whereas in other countries there were not. The progress interruption, in terms of growth of students were much more severe when there were lockdowns than in other countries. So in terms of education around health, awareness of your own bodily autonomy, in terms of making decisions, these are things that should actually be fostered already at young age in schools and help students to make informed decisions. I mean, simple things like showing them the dangers of alcohol consumption, of vaping, tobacco use, narcotics. These are things that in today's life, you cannot rely on families and parents to teach all the time. I mean, these need to be taught in educational institutions, and there needs to be peer group discussions about it. That's the only way really that you will make a difference. And in terms of realizing, I mean, you find in many of the poorer societies all over the world, when women become ill, particularly with something that they may feel they will be discriminated against if it becomes well known in their family, they simply refuse to seek medical care. A lot of this is also based around stigma of disability, stigma of people with disabilities, stigma about people that have mental health conditions. This is something, I mean, this is unfortunately another of those blights on society that I talked about earlier. And you also find it not only among the poorer sectors of society. I mean, there are there are different reasons why it happens. So I think it's a societal issue. It's very difficult for the health sector to address it independently. It's a lot like the work we do around road safety, for example. Much of what we do around road safety, advocating for child restraints, for motorcycle helmets, for seat belts, for safety standards in vehicles. These are things that the health sector, when there is a crash, and this is one of the leading causes of death for adolescents, for example, and injury, the health sector is the recipient of those that are injured in the crash. But the health sector cannot move on its own. It has to work with the infrastructure, education, transport, traffic control, the people that do the signage on the roads, justice for the speed, the law enforcement. So there are many ways, I think, that you can deal with these problems if you make it a whole of government or more of a whole of society problem to solve.
Great, thank you very much. We have another question from Dr. Bill Hunter. I think it's a very interesting question about the polio epidemic. Something we've been working on, as you know, everyone knows the U.S. efforts to eradicate. There's a long history of vaccine efforts, and it's global health effort to completely eradicate polio. And his question is, Rotary International and the Gates Foundation have teamed up to eradicate polio. How does polio turning up in the New York City set back these efforts? Once polio is eradicated, what specific diseases should these two organizations turn their funding toward next with the likelihood of eradication?
Well, it's very difficult to eradicate a disease. We have done so with smallpox. We are very close to doing it also with polio, but there are two different kinds of polio. So the polio that we are vaccinating against still in those two countries which are not fully under control, which are Pakistan and Afghanistan. Nigeria is now polio free. These are where Gates and Rotary have invested with us and the CDC the bulk of the funding. But then you also have a polio which is the result of a reaction to the vaccine. So it's not a wild polio virus. This is something that is a lot like tuberculosis, if I may make a comparison. If you have not been vaccinated against tuberculosis, there are 1 in 4 people will become ill with tuberculosis at some point, simply because 1 in 4 people carry the bacterium. But it does not mean that 1 in every 4 people will become ill. They can become ill. So if there is an introduction of a bacterium or a fungus or a virus in society where this has not existed for a long time, then you will have outbreaks. It doesn't mean that it will become endemic again. So the outbreak in New York are in certain sectors of towns, where there is resistance to vaccines. And that is why it has happened there. And it's not only in those communities where you see a renewed flare-up of things like polio, the polio virus. The same happened in those communities in terms of measles. And you will see it happen repeatedly because different school system, the laws of the state, New York State, not being implemented in terms of mandatory vaccination for school-going children. So these are things that will be introduced as people travel across the world, and they bring back the viruses and the bacterium with them. I'm afraid it's something that we have seen it in not only here in the USA, we've seen it in Angola. There were large outbreaks of polio in that country as well. We've seen measles outbreaks. We've seen outbreaks of pockets of cholera in Latin American countries that have also been declared free. So these are things, malaria, in fact, in a country like Peru, given their elevation, malaria had not occurred there for something like 25 years. But because of climate change and movement of people, mosquitoes travel just as well as a virus. You see this happening.
Thank you. That's an excellent point. Yeah, I was in London recently, and I remember in the news some traces of polio being detected in London, and now New York. And it's really, like you said, it's very surprising to see that it coming back to cities.
Yes.
And so we have to really be vigilant of that. And thank you for discussing the two different forms of polio. I think that's so important to highlight. I know that Emma had another question that she'd like to ask. We don't have any further questions from the audience, but Emma, would you like to follow up on one of the questions that you had?
Sure. This is a fairly general question. Like, just given everything we've talked about and mostly the barriers that tend to impede the work that the WHO can do, and how long you've been in this sector, how do you stay motivated despite all of this?
Yeah, I knew you'd ask a difficult one towards the end. Bill, I did not skip the Gates Foundation question on purpose, but the Gates Foundation is our largest donor, so I don't want to upset people unnecessarily. Let me just say that, there are different ways that philanthropists address investing in public health. There are those that invest in more long-term areas where there is a severe level of underfunding, but can make a difference in the lives of many, many people, and save the lives of hundreds of thousands of people every year. Those are the Michael Bloombergs that invest in road safety, drowning prevention, mental health, tobacco cessation programs, healthier cities, bike lanes, green spaces, things like that. Then there are those that invest in science. Science looking for solutions, looking for vaccines. Now, it is an unfortunate thing that we have learned once again during this pandemic. There is no such thing as a free vaccine, despite our very best efforts. Despite commitments by pharmaceutical companies to provide millions of free dosages to WHO, and we have distributed almost 2.5 billion vaccine dosages up to today, free. But the same countries renege on their commitment to provide us with vaccines because they find a willing buyer and then they become a willing seller. So a lot of the investment in developing vaccines, whether it's for cancer, whether it's for HIV, at some point down the road is going to have a commercial application. So I think that there is a lot of benefit in investing in it, but it's like somebody investing money on the stock market. You have to spread the risk, and you have to look for returns that are even across the board. So if you ever talk to Bill Gates again in the near future, maybe that can be a piece of advice. Yes, in terms of, I get asked that question a lot. I'm not a medical professional. I'm a political scientist by training. And our office here in New York consists of people that are trained in economics, in social development, people like me who have trained in political philosophy and science, also in economics. There are others that have medical qualifications. So we are a good spread. And the reason for that is we don't work specifically on disease programs. That is done in Geneva, and with the 800 or so collaborating organizations we have across the world. So a lot of the work we do here are with the governments, the diplomatic missions, to work towards global consensus in areas where you can make a change. Because when all the health ministers congregate in Geneva once a year in May for the World Health Assembly, they talk about the epidemiology around health problems. But they don't talk about the politics around health. So it's very important for organizations like ours to invest time in health diplomacy, in health security, in health economics, because you will get nowhere if you talk about the need to look at health as a driver, an outcome, and an indicator of sustainable development, without having people outside the health sector understand it and talk about it. Otherwise, it becomes one of those old cliches, you know, of people singing hymns in the church, and only the people in the church know the hymns. So that's the bulk of the work we do here. So, yeah, it's been a tiring couple of years for us because in addition to the work we usually do, we are also tasked to be the support for the Deputy Secretary General and the Secretary General of the United Nations. So everything they need to know about COVID, that they want to say about COVID, that they want to promote about COVID, this is also our responsibility here. So it doesn't mean that we don't focus on disease-specific issues. We do, but we have a much broader remit. So like with any high stress environment, working for the WHO, I always say, you know, it's going to affect your mental health because it's a difficult organization to work with. And you work with topics that you are always under pressure of some kind and underappreciated for the most part. What makes a difference for me in my life is, you know, I like working with people. I sometimes become impatient with people, but that's something that I can deal with internally. But I like working with people. I like making a difference in people's lives. So if you listen to all that long dramatic list that was read up at the beginning about all the high-level meetings we have been working on here, not only me, but all the unseen colleagues around me, these are global commitments on all the many topics you heard: antimicrobial resistance, universal health coverage, tuberculosis, road safety, non-communicable diseases. These are topics where heads of state come, presidents and prime ministers, and they endorse what is negotiated here. Global benchmarks, spending funding on research and development, reaching 1 billion more people with universal health coverage. These are things that heads of state commit to. So you know when they go back to their countries, they instruct all the ministers in their cabinet to get a move on, because it's then for them a political priority. So those are important things that we get to do here, which our colleagues in Geneva perhaps don't get to do, and where we can make a concrete difference in the lives of many, many millions of people across the world. So that's a nice thought, you know, to wake up in the morning if you're tired and you have to drag yourself through the snow to come to New York City and work. If you can make the difference, a positive difference in just 2 or 3 people's lives that day, it's worthwhile.
Is that all your questions, Emma?
Yeah, that's all. And I just want to say thank you, Dr. Obermeyer, for being here, taking the time, and we appreciate everything you do.
And yes, I'd like to echo that, Dr. Obermeyer. Thank you so much for this wonderful discussion. As a fellow political scientist, I couldn't agree with you more on on how we need to address the political aspects of health. And I think we often neglect looking at the political importance of political commitment and how to achieve that political commitment. So I thank you so much for all your work in doing that and achieving that at the WHO headquarters in New York. And I think that are there any further? We're just about out of time now. I would just like to thank you once again for taking the time to join us today, Dr. Obermeyer. It's been certainly a wonderful, an honor for you to join us. We realize how busy you are with your schedule, and I've certainly learned a lot. I'm sure our students and our audience have. And I'd like to thank you so much for this wonderful opportunity that you've provided with us today. And I'd like to remind all of the audience that is joining us on Zoom that we will be having another colloquium series again in the spring, and to please pay attention to our social media advertisements. But thank you so much, everyone, for joining us for this colloquium event. And thanks again, Dr. Obermeyer, for this wonderful presentation and for joining us. And I look forward to seeing everyone again today at another of our colloquium series.
May I just also thank all of you for taking time off in your busy day and foregoing your lunch to listen to me. It has been an honor for me to have this conversation with you. And if there is anything you want to follow up with us, we are always at your disposal. We always have time. We will find time. So that's not a problem. Thanks a lot.
Wonderful. Thank you so much, sir. Take care. Bye-bye, everyone. Bye-bye.
Bye-bye.